What about the high-risk medication list? What is that?
Well, whose list? Who's high risk?
Well, who do you define as high risk?
Yeah.
In the elderly?
Well, there's many conditions, many classes of pharmaceuticals that are considered high risk, one of which is treating insomnia, sedative hypnotics. But there are many, many others. And again, that's a list defined a lot by the Beers criteria. So that's what we look at, and we try to do what we can by alerting the physicians with whom we contract if we see from our pharmacy claims data a patient receiving high-risk medications.
You know, one of the things that occurs to me is that as patients grow older, and not as an individual necessarily, but an aging population, the incidence of primary neurologic disorders simply goes up. It is. Whether you get Alzheimer's disease, you get Parkinson's symptoms. What are the challenges of insomnia in patients with pre-existing and perhaps progressing neurologic disease?
So you're up in the ante here because...
I just did.
Right, because you're not only dealing with the patient, their level of function, how well they do during the day, but now you're dealing with the caregivers. And sort of one of the things that will push families to have to institutionalize a family member is that they can't sleep at night. And so a lot of times getting the patient to sleep at night becomes a crisis for the family because the patients will wake up in the middle of the night, they may wander around, and they're very unsafe, and they can wander out. So it creates a lot of, and very disruptive, so it creates a whole different set of dynamics for the family. And the imperative of treating it, and these patients are not going to respond very well to cognitive behavioral therapy, obviously, and so you're really more pushed into treating them medically.
Okay, and do some of these other techniques work even with neurologic impairment? For example, sleep hygiene, getting to bed at a regular time.
Sure.
Trying to get them to bed.
Some of the things that Carl mentioned, and addressing caffeine, regular bedtimes, minimizing fluids perhaps before they go to bed so they don't have to wake up to go to urinate.
Okay. And do you see, even with these neurologic impairments, an improvement in the overall patient well-being if you can regularize or normalize their sleep cycle?
That's much harder because you're dealing with a disease that's progressing anyway. No matter how good you are at treating their sleep, they're going to progress. You may just make them function better, a little bit better during the day, and you improve the quality of life of the caregivers, so you just improve the whole mix. So it's hard to tell. Is it going to alter the course of the disease? It's very hard to tell.
I mean, it would seem to me that whatever would make you more neurologically functional, if you have no impairment, would certainly make you more functional with some impairment, and perhaps it's even more important.
It's some things that oftentimes I have patients come to me who say with somebody who has late stages of Alzheimer's disease, and they may have been one of these patients who just stopped sleeping. And they're convinced if I got them to sleep at night, they would be much better during the day. And the problem with that is that that particular patient population, in order to get them to sleep at night, you almost have to over-medicate them. And so their function during the day and your ability to judge that is sort of distorted.
Are there limitations on the therapy for insomnia that you can use in patients with pre-existing neurologic disease?
Well, just that you have to be more cautious. You have to be more cautious about the benzodiazepines that Nicole mentioned, for instance, that you're going to increase the level of confusion, you're going to increase their level of their gait disorder, their balance difficulties that a lot of them may already have, and you have to balance that. And you have to balance that against what's the risk. And there are difficult cases to deal with, and we may even deal with a class of medications that we haven't even mentioned, depending upon the stage of the patient and so forth. We may even use things like antipsychotic medications that we really haven't addressed here that don't necessarily target their sleep as it is to target their overall level of agitation. Yes, you have to worry much more so about the side effects, but the whole equation changes.